Good afternoon, everyone. Today we are going to study about the thyroid hormone drugs which will inhibit the thyroid secretion and release. Okay, what we will call it as thyroid drugs and anti-thyroid drugs. Now, first one, what is this thyroid? It's a hormone produced by the thyroid gland, and thyroid gland is composed of million clusters of follicles. Okay, and coming to these follicles, these are spherical and consist of epithelial cells surrounding a central mass, which we will call it as a colloid. And the hormones that are produced from the thyroid gland are T3 and T4 hormones are produced from the thyroid gland. Okay, and next one is uh, we also have got another group of cells, that is parafollicular cells, which are present in between the follicles of thyroid gland, which will secrete the hormone calcitonin. Okay, now in this slide, what you are going to see is this one follicular cell. Okay, on your right side, you can see the one follicular cells, which has also got parafollicular cells, which will producing calcitonin. Okay, this follicular cells has got epithelial cells followed by a central colloid. Okay, and this colloid has got thyroglobulin protein. Okay, so this is about the follicular cells. Next one, coming to the functions of thyroid hormone. What are the physiological actions of thyroid hormone? T3 and T4 plays an essential role for the growth and development. Okay, T3 and T4. So these thyroid hormones are required for the growth and development. Okay, first one. Next one is this thyroid hormones plays an important role in metabolism. Metabolism of what? Metabolism of lipid, metabolism of carbohydrate, and metabolism of proteins. Okay, and this T3, T4 hormone all will increase the BMR by stimulating the cellular metabolism. It also helps in maintaining the body temperature. Okay, calorigenesis will happen because of the thyroid hormone. Energy production and metabolism of lipid, carbohydrate, and proteins will increase the basal metabolic rate, and it also helps in maintaining the body temperature. And next one, on cardiovascular system, it stimulates the heart by direct action on the contractile elements and by probably up regulation of beta adrenergic receptors. Okay, when this upregulation of beta adrenergic receptors are seen, this is seen mostly at hyperthyroidism. Upregulation of beta adrenergic receptors is mainly seen with the hyperthyroidism. On heart, what are the actions for thyroid hormone? First thing is it will stimulate the heart by direct action on the contractile elements. The next one is it will upregulate the beta adrenergic receptors. And next function is on nervous system. This thyroid hormone will plays an important role in nervous system. It plays an important role for the activity of nervous system. If there is any deficiency of thyroid hormone, then it causes various effects. That is, it may cause cretinism wherein it affects, and it may cause myxedema in adults. Okay, why this cretinism and myxedema is going to happen? It is going to happen because of decreased production of thyroid hormone. So it explains the importance of thyroid hormone for normal nervous system activity. The next one is on skeletal muscles. On skeletal muscles, what it do means it is important for maintaining the tone of skeletal muscle. Okay, thyroid hormone is important for maintaining the tone of skeletal muscle, followed by GIT system on GIT. How this thyroid hormone will act on GIT is these thyroid hormone plays an important role for the peristaltic movement. If thyroid hormones are decreased, then the peristaltic movements will be decreased. If thyroid hormone levels are increased, then peristaltic movements will increase. Thereby, it causes constipation and diarrhea respectively. Okay, the next one is hemopoiesis. This thyroid hormone also plays an important role in the generation of pregnancy. Whenever hypothyroid state is there, then there is some degree of anemia is observed. And next one on reproduction. What is the action of thyroid hormone on reproduction? Means it has an indirect effect on the reproduction. Now, these are the physiological actions of thyroid hormone. Next thing, what we are going to do is thyroid hormone synthesis. We are going to study the thyroid hormone synthesis under these side headings, that is iodide trapping, oxidation of iodides, iodination of tyrosine, coupling, storage and release, transportation, and peripheral conversion of T4 to T3. Under these side headings, we are going to study about the thyroid hormone synthesis, storage, release, and peripheral conversion. Now, first step is iodide trapping. Okay, whatever the iodide that we take will be, iodine that we take is present in the iodide form. Now, this iodide will be taken up by the follicular cells. If you remember the image in the second slide, we have seen the follicular cell. On the follicular cells, it is surrounded by the epithelial, and centrally we have. On the epithelial cells, we have a protein which act as a supporter, and the protein is sodium and iodide supporter. Now, what is the function of this protein means? It helps in the transport of iodide into the follicular cells. And what type of transport it is? It's an active transport. For every transport of iodide into the follicular cells, it requires energy. Now, we have substances which will increase the iodide uptake, and we have substances which will decrease or inhibit the iodide. Iodide uptake enhancers are the thyroid stimulating hormone, iodine deficiency, thyroid stimulating hormone receptor antagonist. These are the substances which will increase the uptake of iodide. The next one is iodide uptake inhibitors. And iodide uptake inhibitors are iodide ion. Whenever the plasma levels of iodides are high, then it will inhibit its own uptake. Okay, and we also have drugs like digoxin, thiocyanate, perchlorate. These are the drugs which will inhibit the sodium uptake by inhibiting the protein called as sodium iodide supporter. Okay, now first one iodide trapping we have completed. Next one is oxidation of iodides. Now whatever the iodides that entered the follicular cell, this one is not so reactive. So what is going to happen in the epithelial cells of follicular cell means here this iodide will be converted into reactive iodine. Okay, this one is highly this iodide will be converted into reactive iodine with the help of the enzyme peroxidase. Peroxidase is the enzyme which helps in the conversion of iodide to iodine. Now iodine then pass through the apical membrane into the colloid. From the epithelial cells, iodide has entered into the epithelial cells. Inside the epithelial cells, this iodide has been converted into iodine, and this iodine will be passed through apical membrane to where? To colloid. Now, next step is iodination of tyrosine. This iodine, as it is highly reactive, in the last slide we have seen that whatever the iodide that is converted into iodine is more reactive. This iodine reacts with the tyrosine residues which are present in the thyroglobulin. What is present in colloid of follicular cells? Colloid consists of thyroglobulins. Okay, and it along with that it also has got a T3, T4, MIT, and DIT, which we are going to see now. Okay, what this iodine will do? This iodine will react with the tyrosine to form monoiodotyrosine and diiodotyrosine. If one iodine will combine with the tyrosine, then it will form the monoiodotyrosine. If two iodine molecules react with the tyrosine, then it will form diiodotyrosine. And for binding to the tyrosine, it requires an enzyme, and the enzyme is same enzyme, that is thyroid peroxidase. Thyroid peroxidase act as a catalyst for binding of iodine to the tyrosine. This process is called as organification of iodine. Okay, next one is what we have seen till now. First one is iodide will enter into the follicular cells. In the follicular cells, this iodide will be converted into iodine, and this iodine will be transferred from the follicular cells to colloid. And in the colloid, this iodine will react with the tyrosine with the help of the peroxidase enzyme to form monoiodotyrosine and diiodotyrosine. Now, this next step is coupling, where monoiodotyrosine and diiodotyrosine will combine together to form T3, that is triiodothyronine, and two molecules of diiodotyrosine will combine together to form thyroxine, that is T4. Okay, and again, same enzyme, peroxidase enzyme act as a catalyst for coupling of mono and diiodotyrosine. Normally, high amount of T3 is formed. And next one, in cases of iodine deficiency, what our body will do is it will start producing more number of monoiodotyrosine. Why more number of monoiodotyrosine? This more number of monoiodotyrosine helps in formation of T3. Why T3 is required? Because T3 is the active form of thyroid hormone. T3 will highly reacts with the thyroid receptor to do its activity. Okay, functionally T3 is superior. By production wise, T4 will be produced more. That's why in the last point we have a last step. We are going to study about the peripheral conversion of T4 to T3. Next step in thyroid hormone synthesis is storage and release. Now, whatever monoiodotyrosine, diiodotyrosine, T3 and T4 that are produced in the colloid will be attached to the thyroglobulin and stored in the colloid. Okay, when it is released, when thyroid stimulating hormone will come and bind to the thyroid stimulating hormone receptor which are present on the thyroid gland, then it will release the thyroid hormone. Thyroid gland will release the thyroid hormone. Thyroid hormones will be attached to the thyroglobulin. Will be this thyroid hormone which is attached to the thyroglobulin will be taken up by the follicular cells by a process called as endocytosis, and it will be broken down by the lysosomal proteases. substances, because colloid is like a sticky type of substance which has got monoiodotyrosine, diiodotyrosine, T3, and overall follicular cells. What it will do? It will pick up some colloid which has got thyroid hormone by a process called as endocytosis. When it has taken the colloid which has all these substances, it will be broken down by the lysosomal proteases enzymes. Now T3 and T4 will be released along with the monoiodotyrosine and diiodotyrosine. These will be get iodinated, and iodine will be reutilized for the synthesis of again monoiodotyrosine and diiodotyrosine. Then this T4 and T3 will be released into the circulation from the follicular cells. Now, whatever the T3 and D4 will be released, of these T3 and D4 will usually bind to the plasma proteins. Whatever the unbound or free form of hormone is there, it will show the physiological action, and this hormone will get metabolized. Now, to which proteins it will bind means we are going to see. Thyroid, 99% of thyroid hormone will binds to the plasma. Now, whatever the thyroid hormone that is released from the follicular cells, of which 99% will be bind to the plasma proteins, and only 1% will be present in the free form, where it will show its actions and undergo metabolism. To which proteins it will bind means thyroid hormone will binds to the three plasma proteins mainly, that is thyroxine binding globulin, thyroxine binding prealbumin, and thyroxine binding albumin. These are the three proteins which will bind to the T4 and T3. No. As I said earlier, T3 is the active form, but production wise T4 is more produced. So there is a step called as peripheral conversion of T4 to T3. This peripheral conversion of T4 to T3 is converted by an enzyme called as 5' deiodinase enzyme. This 5' deiodinase enzyme helps in conversion of T4 to T3. Okay, and we have three types of deiodinase enzymes are there, and those include deiodinase 1, which is present in the liver and kidney, and deiodinase 2, which is present in the brain, skeletal muscles, and cardiac muscles. And the last one is deiodinase enzyme 3, which is present in the plasma, skin, and some extent in brain. Now, from the slide, from heading of the slide, we can say that T4 will be converted into T3. But what is going to happen is T4 will be converted into T3 as well as reverse T3, which is called as RT3. When this RT3 is produced means whenever T4 is encountered by the DID3 enzyme. Whenever T4 is encountered by the DID3 isoenzyme, then from T4, instead of producing T3, what it will produce means it will produce the RT3 form. Now, this RT3, this one is not active thyroid hormone. Okay, it cannot bind to the thyroid receptors, or it cannot show the actions of thyroid hormone. So ultimately what is going to happen is this RT3 will be again further metabolized, and iodine will be reutilized for the synthesis of thyroid hormone. Okay. Now, thyroid hormone regulation. Now, whenever the thyroid hormone levels are increased in the plasma, then it shows negative feedback mechanism. Where means it acts on the pituitary and hypothalamus. On pituitary, what it will do? It will inhibit the release of thyroid stimulating hormone. On hypothalamus, what it will do? It will inhibit the production of thyroid releasing. This is how thyroid hormone will exhibit negative feedback mechanism and regulates its own release. Now, mechanism of action of thyroid. As I said earlier, T3 is the most active protein which shows the actions of thyroid hormone. Now, this T3 binds to high affinity thyroid receptor, and this thyroid receptor binds to the DNA sequence in specific. Okay, now this T3 hormone with the thyroid receptor complex will acts or modulate the gene transcription and enhance the protein synthesis. Okay, thyroid hormone, vitamin D, steroid containing substances will act on the specific segment of DNA, on specific genes, and what it will do, either it will produce the increase the protein synthesis, required protein synthesis, or it will inhibit the protein synthesis. Here, what the thyroid hormone will do? Thyroid hormone will increase the production of specific proteins. Okay. Now, T4 binds with lower affinity than T3, but does not alter gene transcription. As I said earlier, T3 is more active, but T4 will also bind, but it cannot alter the gene transcription. Which substance can alter the gene transcription? T3. T3 hormone will alter the gene transcription. T3 causes all actions of thyroid hormone at transcription. Now, thyroid disorders. What can be the thyroid disorders? Either hyper or hypo. If it is secreting more, then hyperthyroidism. If it is secreting less, then it is hypothyroidism. Now, hypothyroidism is a syndrome hypothyroidism is a condition resulting from deficiency of thyroid hormone. And common conditions which causes hypothyroidism are cretinism, myxedema, and Hashimoto's thyroiditis. These are the conditions which causes hypothyroidism. Next one is hyperthyroidism. Hyperthyroidism is a disorder from the overproduction of T3 and T4 hormone. When this T3 and T4 hyperproduction is seen, conditions like Graves' disease, toxic uninodular or multinodular goiter, and subacute thyroiditis. These are the conditions where hyperthyroidism will be seen. That is, hypersecretion of thyroid hormone is seen in these conditions. Now, we are going to study about the hypothyroidism first. First one is cretinism. Now, cretinism is a hypothyroid condition which is seen in children or infants. It might be either endemic or sporadic. Endemic means where it is seen in a particular place where the iodine deficiency is high. And the sporadic means there is failure of thyroid to develop normally or defective hormone synthesis is seen in infants. Okay, usually it is detected at the birth. If it not recognized, it will be detected by the age of 3 to 5 months. And if it is not treated, what is going to happen is the following features will be seen in the children, the infants. The features are dwarfism, mental retardation, short extremities, inactive, listless, puffy, expressionless face, enlarged tongue, pot belly, skin will be yellow color, dry and cool, bradycardia, low body temperature, late teeth eruption, delayed closure of fontanelle, poor appetite, feeding will be slow, constipation, and umbilical hernia. These will be seen these are the characteristic features present in cretinism. Now, by seeing these features, you can understand the importance of thyroid hormone. In thyroid functions, what we have studied, what we have seen that thyroid is important for the growth. Now, if thyroid is not there, what is going to happen? First feature of cretinism, dwarfism. We have seen that thyroid is important for the nervous system activity. What is going to happen? Thyroid is not there, mental retardation. Here, with the features of cretinism, you can understand the importance of thyroid hormone. Okay, now let's go to the next slide. The next is Hashimoto's thyroiditis, which is a chronic autoimmune disease where our body starts producing against our own cells. Here, what is going to happen is antibodies will be produced against the thyroglobulin. Okay, because of this, the T3 and T4 levels will be less, or low levels of T3 and T4 will be there, associated with elevated TSH levels. That is, thyroid stimulating hormone is trying to stimulate the thyroid gland, but there is no adequate production of T3 and T4 hormone. That's why the laboratory findings will be low levels of T3 and T4 with elevated TSH levels. The next one is non-toxic goiter. In non-toxic goiter, there is deficient production of hormone, leads to excess TSH enlarged, and this excess TSH causes enlargement of thyroid gland and increases the iodide trapping and produces adequate quantity of thyroid. Okay, this enlargement of thyroid gland, why it is happening? Because of excessive stimulation of thyroid stimulating hormone and iodide. Now, next one is adult hypothyroidism, which we'll call it as myxedema, and causes of myxedema are autoimmune thyroiditis and thyroidectomy. Okay, these are the two causes of hypothyroidism in adults. And with some drugs like iodine 131, which is a radioactive isotope, which we are going to study in the next slides. With iodides, lithium, and amiodarone. These are the drugs which causes hypothyroidism in adults. Now, coming to the characteristic features of myxedema, the characteristic features are: face will be expressionless, puffy, the skin will be cold, dry, scaly scalp will be present, and hair will be coarse, brittle, and sparse. The next one is fingernails will be thickened and brittle, and voice will be husky, low-pitched voice, and slow speech is present. And the patient will have poor appetite and constipation. Here, why constipation is occurring? Whenever thyroid hormone levels are decreased, then peristaltic movements will decrease. Okay, and remember, here in hypothyroidism, we are seeing constipation, whereas in hyper, what we are going to see? Opposite, that is dilation. The next one is voluntary muscles will become weak, and relaxation of deep tendon reflexes will be delayed. And along with that, dilated heart, pericardial effusion, ascites, hyperlipidemia, and anemia are seen. And these people are cold intolerant. Okay, these are the characteristic features which are present in myxedema. And next one is myxedema coma, is an extreme complication of hypothyroidism, in which patients exhibit multiple organ abnormalities and progressive mental deterioration. Okay, it's a medical emergency with high mortality rate, that is 60%. Despite early diagnosis and treatment. Decompen- sorry. Decompensation into myxedema coma occurs when hypothyroid patients' homeostatic mechanism are disturbed. Whenever coexistent diseases or infections causes disturbance in hemostatic mechanism, then this myxedema coma will be present. Okay, hypothyroid patients with disturbed hemostatic mechanism. These two are the triggering factors or conversion of myxedema to myxedema coma in adults. Now, thyroid preparations, we have two types of thyroid preparations are there. For T4, we have levothyroxine, and T3, leothyronine. Therapeutic uses in cretinism, if it is a case of endemic cretinism, then iodine preparations is given in pregnancy till the end of second trimester. If it's a case of sporadic, then treatment will be done with the thyroxine 8 to 12 micrograms per kg daily and should be started as soon as possible. And next one is myxedema. In myxedema, T4 is given at low doses of 50 micrograms daily and increase every 2 to 3 weeks to an optimum of 100 to 200 micrograms per week. Next one is non-toxic goiter. T4 is the replacement therapy. In papillary carcinoma, unresectable cases, T4 will suppress the endogenous production of TSH and may induce the temporary regression. Okay, these are the therapeutic uses of thyroid hormone preparations in hypothyroidism. Now, next one, in myxedema coma. As I said earlier, it's a medical emergency with high mortality rate. And what is the treatment for myxedema coma is ventilatory support, rewarming of the patient, and correcting the hypothermia, followed by IV steroid should be given, and the main treatment is IV T4 will be given at the dosage of 200 to 300 micrograms at bolus, followed by 100 micrograms will be given after 24 hours. Now, next is then the patient will be shifted to oral T4 preparation at the dosage of 500 micrograms. Now, in the initial slides, I have said that T3 is the most active form. If T3 is the most active form of thyroid hormone, why we are giving T4 in emergency? Why can't we give T3 in emergency condition like myxedema coma? Why can't we give in other hypothyroid conditions? Why? Why in the previous slide also I have said only about T4. T4 is used in this, T4 is used in that, T4 is used in this. But I have never mentioned about the T3. Why T3 is not used even though it is very active thyroid hormone? Because whenever T3 is given, it causes cardiac complications. That's why T3 is not given much, T4 is preferred. Okay, now if in this condition, that is in myxedema coma, if patient does not respond to T4, then we will go for T3 will be given at 10 micrograms 8 hours. And even though T3 is given, this T3 will be given only in patients below 55 years of age. Or if at all, it has to be given for the patient who is above 55. The areas will be monitored closely. Next one is hyperthyroidism. As the name itself explains, it's a overproduction of thyroid hormone. Okay, thyrotoxicosis is a syndrome of excess of thyroid hormone in the blood, causing a variety of symptoms that include rapid heartbeat, sweating, anxiety, and drowsiness. Okay, now what are the causes of thyrotoxicosis? That is, what are the conditions where thyroid hormone levels in the blood will be increased? Conditions like Graves' disease. Graves' disease, where our body, again same, Graves' disease also an autoimmune disorder, autoimmune disease, and the overproduction of thyroid hormone by the entire gland is seen in Graves' disease. The next condition is toxic nodular or toxic uninodular or toxic multinodular gout, where the excess thyroid hormone production will be present. Next one is thyroiditis. It's a temporary symptom of hyperthyroidism. Why it is occurring? Because of leakage of thyroid hormone, thyroiditis will, or because of excess intake of thyroid hormone preparations also causes hyper. The laboratory findings will be high T3 and T4 associated with low TSH. Now, the clinical features of hyperthyroidism. In hyperthyroidism, there will be increased basal metabolic rate. The patient will be heat intolerant, tachycardia, increased cardiac output, cardiac arrhythmias, menstrual irregularities, warm, moist skin will be present, hyperglycemia, skeletal muscle weakness with muscle wasting, tremors, diarrhea, weight loss, insomnia, hyperreflexia, and nervousness are the characteristic features of hyperthyroidism. Along with all these characteristic features, exophthalmos and dermopathy are present in Graves' disease. If you see the image in this slide, these images of Graves' disease where exophthalmos and dermopathy are present. And this image is taken from New England Journal of Medicine. The next one is thyroid inhibitors. And this first group of drugs are which will inhibit the hormone synthesis. Or these drugs are also called as antithyroid drugs, are also called as thiazolamides. The drugs include propylthiouracil, carbimazole, and methimazole. The next one is the drugs which will destroy the thyroid tissue. The drugs are radioactive iodine preparations, iodine 131, iodine 125, and iodine 120. The next one is which will inhibit the hormone production and release. The drugs are iodine, iodides of sodium and potassium, and organic. These are the substances which will inhibit the hormone production and release. The next one is ionic inhibitors. The substances are thiocyanate, perchlorates, and nitrates. Nowadays, these ionic inhibitors are not used because of adverse effects associated with the ionic inhibitors. Now, coming to the mechanism of action of the antithyroid drugs. Antithyroid drugs will bind to the thyroid peroxidase and prevent the oxidation of iodides and iodotyrosyl residues. That is, first step, that is conversion of iodide to iodine will be inhibited. Why? Because these drugs will inhibit the enzyme peroxidase. And the next one is will prevent the binding of iodine to tyrosine residues. Thereby, it will inhibit the production of monoiodotyrosine, diiodotyrosine, T3 and T4. How? By inhibiting the peroxidase enzyme. If you recollect the importance of peroxidase enzyme in the synthesis and release of thyroid hormone, then you can understand easily the mechanism of action of antithyroid. The next one is maximum effect delayed until existing hormone stores are exhausted. Now, what these drugs are doing? These drugs are inhibiting the synthesis. So, it requires some time to show the effect. Why? Because already stored or whatever the bond form of thyroid hormones are there, those has to be got exhausted. Then only anti-thyroid effect will be seen. Okay, high doses leads to hypothyroidism. Now this propylthiouracil, what it do is additionally it will inhibit the peripheral conversion of T4 to T3 at high doses, which are used in thyroid storage. Now this one again an important comparison between the antithyroid drugs, that is propylthiouracil and carbimazole. Propylthiouracil is a less potent drug, whereas carbimazole is 5 times more potent. Propylthiouracil highly plasma bound, carbimazole less plasma bound. And propylthiouracil less placenta and milk entry is present, whereas carbimazole it is highly secreted into the placenta and enters into the milk. And propylthiouracil T half is 1 to 2 hours, whereas carbimazole its T half is 6 to 10 hours. And propylthiouracil there is no active metabolite, whereas active metabolite is present for carbimazole and it is methimazole. Propylthiouracil multiple dosing is required. Why? Because of short half-life. And carbimazole single dose is sufficient. And propylthiouracil will inhibit the conversion of T4 to T3, whereas this action is not present for carbimazole. Now, coming to the pharmacokinetic property of antithyroid drugs, all these drugs are given orally, well absorbed, widely distributed in the body, and these drugs process in placenta and secreted in milk. Next is these drugs are metabolized in the liver and excreted in urine. All are concentrated in the thyroid. So, as these drugs will get concentrated in the thyroid gland, the T half of these drugs in the thyroid will be higher. That's why even though methimazole has got 6, T half is 6 hours, one dose is sufficient. The preparations that are available are propylthiouracil 50 mg tablets are available, methimazole 5 and 10 mg tablets are available, and carbimazole 2.5 and 5 mg tablets are available. Therapeutic uses where these antithyroid drugs are used means antithyroid drugs control the thyrotoxicosis, which is seen in Graves' disease and toxic nodular. These are the conditions where there is excess production of thyroid hormone is seen. In these conditions, if we give the antithyroid drugs, it will control the thyrotoxicosis. And clinical improvement will start after 1 to 2 weeks or sometimes more. Why? Because stores has to be got exhausted. Then only the therapeutic effect of antithyroid drugs will be shown. The next one is a remission may occur in up to half of the patients of Graves' disease after 1 to 2 years of treatment. Whereas in toxic nodular goiter, there is no remission or very rarely remission may occur. Coming to the adverse effects, it causes hypothyroidism and goiter can occur due to overtreatment. Next one is side effects like GI intolerance, skin rashes, joint pain, loss or graying of hair, loss of taste, fever, and liver damage may rare but serious adverse effect, that is agranulocytosis, may occur in 1:500 or 1:1000 patients. The next type of preparations are iodine and iodides. These are the fastest acting antithyroid drugs. What they will do is these drugs will inhibit the release of thyroid hormone. That's why these drugs are called as thyroid, or these drugs causes thyroid constipation. Endocytosis of colloid and proteolysis of thyroglobulin comes to halt because of iodine and iodides. And excess iodides inhibit the bone transport into the thyroid follicular cells by inhibiting the sodium iodide supporter on the cells. Next one is it attenuates the thyroid stimulating hormone and cyclic AMP induced thyroid stimulation. Okay, what the thyroid stimulating hormone will do? It will stimulate the thyroid gland. What is going to happen if it gets stimulated? It will produce the thyroid hormone. Now, what these iodide preparations will do? Will prevent or inhibit the or slows the stimulation of thyroid gland by thyroid stimulating hormone. The next one is it also interferes with the iodination of thyrosil and thyronil residues of thyroglobulin, thereby resulting in reduced T3 and T4 synthesis. It will inhibit the synthesis, it will inhibit the release of thyroid hormone from the colloid. Therapeutic uses, these drugs are given pre-operatively for 10 days. What is going to happen if iodine preparations are given pre-operatively for 10 days? The gland will become firm and the size of gland will be reduced. Next one is thyroid storm. In thyroid storm, Lugol's iodine or iodine containing radio contrast media are orally given to stop any further release of T3 and as these act as a thyroid constipating agents. These drugs are given in thyroid storm. And along with that, it also decreases the conversion of T4 to T3 in the peripheral circulation. And iodized salts are generally used as a prophylactic agent in endemic cases. Next one, iodide preparations like tincture iodine, povidone iodine are used as antiseptics. Adverse effects seen with the iodine and iodides, acute reaction which is seen in individuals who are sensitive to iodine preparations. And the manifestations are swelling of lips, eyelids, angioedema of larynx, fever, joint pain, hemorrhage, thrombocytopenia, and lymphadenopathy will occur. And chronic overdosage causes inflammation of the mucous membrane, salivation, rhinorrhea, sneezing, lacrimation, swelling of eyelids, burning sensation in the mouth, headache, rashes, and chest. Long-term use of high doses can cause hypothyroidism and burn. Now, the next group of drugs are radioactive iodine. Only iodine 131 is used medically. Used therapeutically. It's a stable isotope which will exhibit gamma and beta rays. And these beta rays will enter into the follicular cells, thereby causes pycnosis and necrosis, followed by fibrosis of follicular cells. Now, radioactive iodine are administered as a sodium salt dissolved in water, and these substances are taken orally. And where it is used? It is used in Graves' disease and toxic nodular gout. The response is slow, starts after 2 weeks, and peak response is seen at 3rd month or so. Next one, beta adrenergic blockers. Why beta adrenergic blockers? Why in hyperthyroidism? If you recollect the functions of thyroid hormone, what it will do? it will upregulate the beta adrenal receptors. So, if we see the symptoms or characteristic features of hyperthyroidism, few characteristic features are occurring because of increased beta activity on specific receptors. That's why beta adrenergic blockers are used to control the symptoms of hyperthyroidism. Okay, some symptoms are some symptoms will occurs which are seen due to increased beta activity are palpitation, tremors, nervousness, myopathy, and sweating. And beta blockers provide quick relief. The drug is propranolol, which is given at the dosage of 20 to 80 mg, 6 to 8. And this drug is not used as a solo therapy. Why? It just only control the symptoms. It does not control the or cure the cause. So why beta adrenergic blockers? These are used to control the symptoms like palpitation, tremors, nervousness, myopathy, and sweating. Next one is thyroid storm or crisis, where there is an excess release of thyroid hormone is seen, which is characterized by fever, sweating, tachycardia, extreme nervous excitability, and vulnerability, which is a life-threatening emergency. Large amount of hormones will be released into the circulation, occurs in untreated or incompletely treated patients. And especially it is precipitated by any infection, trauma, or toxemia of pregnancy. Now, coming to the treatment of thyroid storm or crisis, first one, propranolol is given by intravenous route, slowly 1 mg per minute to maximum 10 mg, followed by 40 to 80 mg. Oral preparations are given every 8 hours. And along with this, propyl thiouracil 200 to 300 mg, oral 6 hourly, and ionic acid or iodate or iodine containing radio contrast media. They are potent inhibitor of thyroid hormone rise. Along with this, hydrocortisone is given 100 mg 8 hourly by intravenous, followed by oral prednisone. Hypothermia will be corrected by cooling and aspirin drug. If heart failure is not controlled, then we are going for diltiazem, which is given at the dosage of 60 to 120 mg BD orally. With this, we have completed the thyroid and anti-thyroid drugs.